Good morning once again. I'm Dr. Geraldine Zamora, your moderator for today, and I would like to thank our sponsor, Pfizer, and all our participants for joining us today. So please post your questions at the Q&A box, and we will address them during the open forum. You will receive your certificate of attendance after you submit the evaluation form and post-test, and the link will be posted later. Be sure to type in correctly your full name and email address to receive your certificate. So this is the 4th year that we are doing the LMLR online, and today will be the 5th of our webinar series for this year. The LMLR aims to teach rheumatology to healthcare professionals, an advocacy initiated by Dr. Lourdes Manahan, the first Filipino rheumatologist. This year's theme is Life to the Max. We wish to emphasize a holistic understanding of our patients and their diseases, as well as strategies through which we can make our patients' lives better. LMLR is in support of the WHO Sustainable Development Goal 3 on health and well-being and SDG 4 on quality education. The Division of Rheumatology has its book publications, the Atlas of Rheumatic Diseases in the Philippines, and the Physician's Guide to Telerheumatology, and those who wish to purchase copies can do so through our contacts. Our lecture today will focus on early rheumatoid arthritis, recognizing factors for progression of non-specific arthritis to rheumatoid arthritis, and initiating pharmacologic and non-pharmacologic treatment for those suspected with rheumatoid arthritis. We are deeply honored to have 2 distinguished speakers. This couple are both graduates of the UP-PGH. Our first speaker is Dr. Angeline-Therese Santiago. Dr. Santiago completed her residency training in internal medicine and her fellowship training in UP-PGH. She is a clinical associate professor in the UP College of Medicine and currently the training officer of the Division of Rheumatology in PGH. Aside from PGH, she is also an active consultant in San Juan de Dios Educational Foundation, Medical Center Manila, and Hospital ng Maynila Medical Center. Our second esteemed speaker is Dr. Nestor Don Santiago. He completed his residency training in rehabilitation medicine in UP-PGH and attended a clinical transcranial magnetic simulation certification course in Melbourne, Australia. He is a full-time faculty in the College of Rehabilitation Sciences. He is also the clinical interns coordinator in the Department of Rehab Medicine and Sports in the Los Santos Medical Center. Aside from this hospital, he is also affiliated with Metropolitan Medical Center. Ladies and gentlemen, let us welcome Dr. and Dr. Santiago as they share their expertise in today's lecture.
Good morning, everyone. I am excited to discuss with you today about rheumatoid arthritis with a special focus on early RA and non-specific or undifferentiated arthritis, which we also sometimes broadly refer to as Rayuma. So these are the objectives given to me, which will also be the general outline of my talk. By the end of this lecture, I hope that you will learn the definition of early RA, the risk factors for the progression of non-specific arthritis to full-blown RA, and of course, the management of early and preclinical RA. Let's begin with a quick review. So RA is the most common chronic inflammatory arthritis worldwide with a prevalence of 0.5 to 1%. In the Philippines, it has a prevalence of 0.12% to 0.6%, meaning that for every 1,000 Filipino patients with chronic inflammatory arthritis, 1 to 6 of them possibly have rheumatoid arthritis. The typical patient with rheumatoid arthritis is a middle-aged female presenting with pain and swelling of many joints. Usually, there are more than 3 joints affected, and symptoms are usually present for more than 6 weeks. The joints of the hands and the feet are commonly affected, particularly the wrists, the MCPs, PIPs, and there is symmetric involvement. One of the hallmarks of rheumatoid arthritis is morning stiffness that usually lasts longer than an hour. So aside from arthritis, RA can also affect different organs. Examples of more common extra-articular manifestations are your rheumatoid nodules, your interstitial lung disease, vasculitis, Zika symptoms, and hematologic manifestations. So one of the important paradigm shifts in RA happened around 13 to 15 years ago when clinicians recognized the need to diagnose RA early. But how do we define early RA? If you look at the studies on early rheumatoid arthritis, the definitions are highly variable and can range from 3 months to 3 years. But it is generally accepted that early RA is the first 3 months from the onset of symptoms. Of course, in clinical practice, this duration of 3 months may be unrealistic as we have to factor in the delays that can occur from symptom onset to actual consultation. Hence, in the 2012 ACR updates for the treatment of RA, early RA is defined as the first 6 months after symptom onset, during which it is generally believed that no damage has occurred yet. So this is the 2010 ACR-EULAR classification criteria for rheumatoid arthritis. Its official purpose is to classify patients with RA to come up with a homogeneous population in clinical trials. Nevertheless, it is a useful guide in clinical practice to help us diagnose patients with rheumatoid arthritis. Its main advantage, compared to its predecessor, the 1987 criteria, is that it aims to identify RA patients earlier, prior to joint erosions and damage. This set of criteria is comprised of the number of joints with clinical synovitis, rheumatoid factor and ACPA titers, acute phase reactants, and the duration of symptoms. Score is
if there is evidence of definite clinical synovitis in at least one joint plus a score of 6, then a patient may be classified as having rheumatoid arthritis. So the main reason why we want to diagnose early is that we also want to treat early. We refer to the first 2 years, particularly the first 6 months, as the golden period of opportunity, wherein we must treat our patients early, systematically and aggressively to achieve our target of disease control, meaning disease remission or low disease activity, to prevent clinical and radiographic progression, disability, and to increase our patients' quality of life and productivity. The evidence supporting the benefits of our early RA treatment is robust, and this should be our goal in our newly diagnosed rheumatoid arthritis patients. So in the clinical setting, we do not always get the classic or clear-cut cases of RA that we can easily and confidently diagnose. We sometimes get patients like these 2 cases here. So case 1, we have a patient, a 48-year-old female with 8 weeks of painful joints of the hands with morning stiffness lasting more than an hour. On physical examination, she has tender bilateral proximal interphalangeal joints and MCPs, but no swelling is appreciated. She has negative rheumatoid factor, but is low positive for anti-citrullinated peptide antibodies. The CRP is also elevated. For case 2, we have a 35-year-old female who is asymptomatic, but his mother has rheumatoid arthritis. She is a smoker and has positive rheumatoid factor and anti-CCP on routine screening. So for case 1, if you use the 2010 ACR-EULAR criteria, you can only get a maximum score of 4, which does not meet the criteria, the cutoff point for rheumatoid arthritis diagnosis. While case 2, you can only get a score of 2 or 3. Let's say that we have ruled out differentials like crystal-induced arthritis, reactive arthritis, and other spondyloarthropathies, and viral arthritis. Most likely, these patients will be labeled as having undifferentiated arthritis, early arthritis, preclinical RA or pre-RA, or even autoantibody positive arthralgia. So the population of undifferentiated arthritis patients is an area of interest in the field of rheumatology, as numerous studies have demonstrated that 30 to 40% eventually progress to rheumatoid arthritis. Which brings us to the question, what are the risk factors for progression to RA of patients with undifferentiated arthritis? So it is believed that RA begins many years prior to the onset of symptoms, hence the concept of preclinical RA. In 2011, the European League Against Rheumatism, or EULAR, created a study group for risk factors for RA. And they identified the preclinical and earliest clinically apparent phases of RA. These are phase A, wherein genetic risk factors are identified. Phase B, environmental risk factors for RA are present. Phase C, systemic autoimmunity associated with RA is present, meaning you have the presence of your autoantibodies. Phase D, symptoms without clinical arthritis. And phase E, unclassified arthritis prior to phase F, which is your actual rheumatoid arthritis. Patients do not have to pass through all phases, and the phases do not necessarily occur in the same order before RA eventually develops. So let's discuss each phase, beginning with genetic factors predisposing to RA. So genetic factors are important in RA susceptibility. Family history increases the risk of RA 3 to 9-fold. Genome-wide association studies have identified HLA susceptibility alleles such as HLA-DR4, HLA-DRB1 susceptibility allele, as well as other non-HLA-RA susceptibility alleles. What about environmental risk factors? So among the identified environmental risk factors, smoking is the best defined risk factor for seropositive rheumatoid arthritis, as it is a strong stimulus for protein citrullination and generation of your anti-CCP antibodies, more so in the presence of your HLA susceptibility epitope. Other risk factors include viral infections, such as your parvovirus 19, mycoplasma, enteric bacteria, and EBV. Dietary factors such as intake of red meat, vitamin D deficiency, excessive coffee consumption, high salt intake. Hormonal factors, we know that female sex portends a higher risk of rheumatoid arthritis. Breastfeeding, nulliparity, periodontitis, the presence of the bacteria Porphyromonas gingivalis causes citrullination, and increased circulatory leptins, which are present in obesity. So this stimulates pro-inflammatory cytokines, such as your TNF-alpha and interleukin-1, which makes obesity and even dyslipidemia a risk factor for rheumatoid arthritis. So after the first two phases comes the phase of systemic autoimmunity. This is when individuals test positive for rheumatoid factor and anti-citrullinated peptide antibodies, your ACPAs or your anti-CCP, but are asymptomatic. So our second case that we presented earlier falls under this category. Multiple studies showed that RA-related antibodies are present years prior to the diagnosis of RA. ACPAs in particular are highly specific for rheumatoid arthritis and are involved in its pathogenesis. Other autoantibodies that have been identified prior to disease onset are the anti-carboxylated P or your anti-CARP antibodies, the anti-IgG hinge antibodies, and antibodies to Porphyromonas gingivalis. I want to share this study done by Sokolov et al. In 2012 on a cohort of 81 patients with clinical rheumatoid arthritis for whom stored serum was available from 1 to 12 years prior to disease onset. So they evaluated the accumulation of ACPA subtypes over time, and as we can see, the CCP titers and the number of ACPA subtypes are increasing over time, especially in the 2 to 3 years preceding RA diagnosis. The study also noted that the increase of ACPA and ACPA subtypes over time correlated with elevations in inflammatory cytokines like your TNF-alpha, IL-6, your IL-12P70, and interferon gamma, even during the preclinical phase. So it's like the preclinical stage of RA can be likened to a brewing storm. So the next phases are the symptomatic phases. When patients have symptoms without clinical arthritis, or they have arthritis, but they cannot be classified as having RA yet based on existing criteria. So this is where our first case falls under. And at this phase, the important question to ask is, what symptoms or clinical features are associated with an increased risk of progression to RA? Meaning, are there symptoms or signs that can be considered as high risk? So EULAR in 2017 formed a multidisciplinary group of European rheumatologists who identified a combination of clinical features that best characterize patients with arthralgia who are at risk of RA. So these include joint symptoms of recent onset, symptoms located in MCP joints, duration of morning stiffness, more than 1 hour, most severe symptoms present in the early morning, presence of a first-degree relative with RA, difficulty with making a fist, and a positive squeeze test of MCP joints. The presence of 3 or more parameters yielded a sensitivity of more than 90%, while the presence of at least 4 parameters or 4 or more parameters had a specificity of more than 90%. So they concluded that they have identified a measurable set of clinical parameters of clinically significant arthralgia, which can be used in future longitudinal studies. There were even earlier attempts to come up with a prediction rule for disease outcome in patients with undifferentiated arthritis. In this 2007 study, using the data from the Leiden Early Arthritis Clinic with a population of 570 undifferentiated arthritis patients, clinical characteristics with independent predictive value for the development of RA were selected using logistic regression analysis. And the patients were also monitored for 1 year to determine the progression to RA. So the variables are as follows, and the corresponding scores are given here. And each prediction score varied from 0 to 14, and this corresponded to the percent chance of developing RA. So this table shows the observed percentage of patients who experience progression to RA in relation to the calculated prediction score. So as you can see here, none of the patients with undifferentiated RA who had a prediction score of 3 progressed to RA during the 1-year follow-up period. While the higher the scores, the higher the frequency of progression to RA. External validation was done, which showed that with a score of 8, 100% of patients progressed to RA. And those who scored 6 and below, 94% of patients did not develop RA. And this translates to a cutoff level of 8 for initiating treatment and 6 for withholding treatment. So another example is the early rheumatoid arthritis criteria, which aim to develop a classification criteria for early RA based on a large cohort of early inflammatory arthritis patients. So the classification criteria of ERA were developed by incorporating the most sensitive or specific variables. And the study included patients older than 16 years of age with new onset joint swelling at 1 or more joints without any treatment and with less than 1 year of symptom duration. So they included 803 patients, and by the end of the 1-year follow-up period, 64% were diagnosed with rheumatoid arthritis, 251 with other rheumatic diseases, and 38 patients with undifferentiated arthritis. So the classification criteria for early rheumatoid arthritis included the following variables: morning stiffness of at least 30 minutes, polyarthritis of at least 3 joint areas presenting with swelling, arthritis of hand joints, meaning at least 1 area swollen in a wrist, MCP or PIP joint, positive RF and positive anti-CCP antibodies. A patient can be classified as early rheumatoid arthritis if he or she has satisfied at least 3 of these 5 criteria. So this had a sensitivity of 84.4% and a specificity of 87.4%. So a classification criteria model was also constructed for clinical use by substituting the regression coefficient with approximate value. So the total scores ranged from 0 to 10 for each RA patient. And when the cutoff was set at 5, The sensitivity and specificity were 86.4 and 88.4% respectively. Validation of the ERA criteria in a cohort of 197 patients with inflammatory arthritis showed that the ERA criteria was more sensitive than the 1987 criteria, and the area under the ROC curves showed a better performance for the ERA criteria than the 1987 ACR criteria and the 2010 ACR-EULAR criteria. So I have summarized here the known risk factors for RA. It is important to be aware of these risk factors so that we can identify at-risk patients. So this is just a table showing the published prediction models using combinations of known risk factors. So this is something to watch out for as the interest in early RA identification persists. So now that we have discussed the risk factors, the next and most important question is, how do we manage patients with early, very early, or even preclinical RA? We are very fortunate to live in the era of DMARDs. So both conventional synthetic DMARDs, biologic DMARDs, and now we also have our small molecule inhibitors, specifically our JAK inhibitors. So gone are the days when RA patients are treated with just NSAIDs and steroids for prolonged periods. We now have drugs which can prevent the progression of disease. So among patients with RA, once you've established the diagnosis, ideally within the first 3 to 6 months of disease, you start your conventional synthetic DMARDs in combination with glucocorticoids as bridging therapy. And you try to achieve remission or low disease activity at 6 months. After which, if target is not met, you have the option of adding either another conventional synthetic DMARD or a biologic DMARD or JAK inhibitor if the patient has poor prognostic factors like positive RF and or anti-CCP, especially at high levels, high disease activity, and early joint damage. So that's for patients diagnosed with early RA. But what about those in the preclinical phase, particularly those who have clinically significant arthralgia or undifferentiated arthritis? What do we do with these patients? Can we treat earlier and prevent RA? So in the past year, several clinical trials have investigated the safety and effectiveness of early or preventive treatment in RA, focusing on individuals who are at high risk for disease without a clinical diagnosis, and patients with very early disease, or patients with undifferentiated arthritis or early RA. So these are the different preventive intervention trials, which was started in 2000. So the population of these trials included those who are ACPA positive but without symptoms, those with clinically significant arthralgia, those with arthralgia and subclinical inflammation on MRI, and those with undifferentiated arthritis. So the dexamethasone trial investigated the benefit of dexamethasone at baseline and at 6 months. The SAVE trial investigated methylprednisolone. We have 3 studies investigating your conventional synthetic DMARDs. The PROMPT study, which investigated methotrexate. The TREAT Earlier trial, which investigated a combination of methylprednisolone at baseline and increasing doses of methotrexate. And your STOP RA trial, which is investigating hydroxychloroquine for 1 year. So the results of the STOP trial is still pending at present. So we also have trials on biologics to be used in prevention of RA. We have your ADJUST trial, which evaluated abatacept for 6 months. Your ARIA study, which also evaluated abatacept. Your APRIPA study, also evaluating abatacept. Your PRAIRIE study, which evaluated single-dose rituximab with methylprednisolone, and your STAPRA study, which evaluated atorvastatin for 3 years. So among these studies, only 3 trials showed benefit. So I will discuss these 3 trials. So in the ARIA study, it was showed that 25 milligrams weekly abatacept for 6 months led to a decrease in at least one of the MRI parameters of inflammation at 6 months and reduced RA progression at 6 months and 1 year. In the PRAIRIE study, Baseline rituximab with methylprednisolone decreased baseline risk of RA at 12 months and also led to significant depletion of B cells and significant decrease in rheumatoid factor after treatment. So in the treat earlier study, methotrexate with baseline methylprednisolone showed some benefit in delaying onset of RA and decreasing disease-related symptoms, physical impairment, and loss of productivity. So although no treatment was shown to prevent RA onset, it seems that early treatment with rituximab and abatacept delayed onset of full-blown rheumatoid arthritis, and both conventional synthetic DMARDs and biologic DMARDs decreased disease-related physical limitations and increased DAS28 defined remission. So these were the conclusions of this systematic review. Early treatment of at-risk individuals may be effective in delaying RA onset, thereby decreasing disease-related limitations in individuals in the preclinical phase of RA. Whether this may ultimately lead to prevention of RA remains to be determined, and we still need further studies. So the practical advice that we can give our patients, as a clinician, the optimal strategy for these types of patients would be to educate them about the risks, give reassurance, manage symptomatically, and monitor judiciously. We can advise them on modifying known risk factors that are associated with RA. We can advise them to avoid or quit smoking, to treat periodontitis early, to make some dietary modifications, try to optimize body weight or achieve a normal body weight, and to prevent infection. So in summary, early rheumatoid arthritis is generally defined as the first 6 months from symptom onset and prior to the onset of damage accrual. RA begins many years prior to the onset of disease, beginning with the interplay between genetic and environmental factors, leading to systemic autoimmunity and finally disease. There are clinical signs and symptoms that may predict RA, and there are models that can be used to predict the risk of developing RA, which can be used in the clinical setting. Early treatment of RA leads to better outcomes, and there are numerous studies on treatment to prevent RA, but we still need further studies to know if these will be effective in the future in preventing disease onset and progression. Thank you for your attention.
Nicolas, 51 years old po. Na-diagnose po ako ng rheumatoid arthritis 2013 po, May 2013. As in, hindi ko po kayang bumangon mag-isa, hindi ko kayang suklayin yung buko, hindi ko kayang itaas yung aking salawal, ganun po. Basta po hindi ko po kayang maligo mag-isa, hindi ko kayang gumalaw. Doon po nangyari pinaka malalang sitwasyon ko po sa rheumatoid arthritis po.
Ang naging epekto sa akin ng rheumatoid arthritis ay yung nahirapan ako magtrabaho, gawa ng hindi ako makahawak ng ballpen, pati tabo.
Una, sa pagtatrabaho ko, dati nakakapag-apply ako, nakapagtrabaho ko. Kung dahil na nangyari sa akin na nagkaroon ako ng rheumatoid arthritis, wala na po akong lakas loob mag-apply kasi ang iniiwasan ko, syempre pag magkasakit ako, hindi ko alam na ma-aatake na naman siya. Tapos, syempre nakakahiya sa company. So, ganun, hindi ako nakakapagtrabaho na pagdating sa namin sa tulong ng asawa ko sa anak buhay, hindi na po ako nakakatulong. Dahil dun sa rheumatoid arthritis na.
At nakaranas ako ng depress. Akala ko hindi na ako makakalakad. Pero nagawa po ako ng paraan dito. Andyan na hindi na ako halos umaano ng pagkain, tumatanggap. Pero ito ako, nakaraos. Wala rin po akong panggaso sa mga kailangan na gamot. Minsan pumipila ako sa PCSO para makuha ko lang ang kailangan kong gamot.
morning. So today I will be talking about rehabilitation in rheumatoid arthritis. I would like to thank the Division of Rheumatology of the Philippine General Hospital for this opportunity to share some rehab hacks to today's audience in managing rheumatoid arthritis. So my main objective for today's lecture is as stated, so to apply non-pharmacologic management for patients suspected of rheumatoid arthritis in the community setting. So for this morning, let me share with you some rehab hacks that will be helpful for everyone in managing rheumatoid arthritis, even at the community level. So we'll try to make it very simple for everyone. So that's why it's called rehab hacks. So what do we know about rheumatoid arthritis? So as discussed earlier, so it's a chronic systemic inflammatory disease of unknown etiology. It usually presents as bilateral symmetric polyarthritis that affects the hands and feet. Now, its clinical course is generally one of exacerbations and remissions, and approximately up to 40% of patients with this disease becomes disabled after 10 years. Now, knowing this, now what are the problems associated with RA and those suspected with RA? So, as stated here, they experience multiple joint pain, they have decreased flexibility, they have weakness from all the non-movement, they have fatigue, they have decreased functional capacities in doing their ADLs, their work, their community involvement, they become disabled eventually, and they generally have a poor quality of life. So many problems. So after the rheumatologist or the internist sees the patient, they can get referred to us to rehabilitation medicine. So once they get referred, we perform what you call our physiatric evaluation. So what do we do there? So of course, we also start with the history of the present illness. Again, just to get an idea of how the disease is. Afterwards, we also ask some questions about their functional status in terms of their mobility, their activities of daily living, their IADLs or instrumental ADLs such as handling their cell phones, what's their work, and what are the recreational activities that we used to participate in, and other relevant questions of their functional status. We also ask them extensively about their social history, their home environment and living situation, the family support, the professional, and recreational, etc. To give us an idea of what their overall functional capacity is. Now, after the physiatric evaluation, we also do a physical examination, which was already done, but we also take note of the stiffness, the tenderness, pain on motion, swelling of any joints, deformities if there are already, limitations of motion, extra-articular manifestations if there are also already, and rheumatoid nodules. Now, on top of that, we also do a physiatric physical examination. So what is this? So it's basically just a focused musculoskeletal examination. So we do some strength testing also, even if it's crude as shaking hands, opening a bottle of water. We also ask them to do range of motion movements such as lifting their shoulders to be able to determine what is their present functional range. And then we can also do some special tests if necessary. Okay. Now, what are the goals now of rehabilitation for RA and those suspected with RA? So, following goals are as listed. So, number 1 is for the relief of pain. Number 2 is for the improvement in the range of motion. Number 3 is the enhancement of strength and endurance. Number 4 is prevention or correction of deformities. And lastly is patient education and counseling. So these are the basic goals of rehabilitation for RA and those suspected with RA. Okay, so the first goal is for the relief of pain. So my objective is to show the non-pharmacologic pain management. So what can we offer? Well, we offer non-pharmacologic pain management through physical therapy, and one of these is your thermal modalities. So we have heat and cold modalities, which have been proven to be beneficial. No? So as stated here, no? So superficial moist heat and cryotherapy, so heat and cold, can be used as palliative therapy. We also have paraffin wax baths combined with exercises, can be recommended for beneficial short-term effects for arthritic hands. And according to this systematic review also, since patients enjoy thermotherapy and there are no harmful effects, thermotherapy should be recommended as a therapy which can be applied at home as needed to relieve pain. Okay, so we have our lineup of heating modalities. So we have your hot moist packs, we have your paraffin wax baths, wherein you dip your hands or even your feet and coat it with wax so that the hard to reach joints can be touched as well. We also have heating pads wherein they can just use them anytime, no, during their leisure periods or their rest periods. No? So all of these heating modalities, they provide heat bioconduction. We also have in physical therapy other types of superficial heat via convection naman. We have your hydrotherapy tanks wherein water heated to a certain level and the patients can dip their feet or their hands. No? We also have contrast baths wherein the patients can dip their feet or their hands alternately in contrasting temperatures, no, hot and cold, no, until some pain relief is achieved. We also have deep heating modalities via ultrasound, so that we can heat the tissues deeper without overheating the skin and the subcutaneous fat. So it's via the conduction of sound waves. That's why it's ultrasound. We also have our cryotherapy modalities. So we have your ice packs or your cold packs. And then we can also do ice massages. Okay? If there's any particular joint, we can do that. Now, my rehab hacks for thermal modalities, okay? If there's no physical therapy or there's no rehab med specialist in your area, you can actually just give this simple advice. They can apply their hot packs. They can use boiled water, put it in a bottle, wrap it in towel, and apply it for 15 to 20 minutes, 2 to 3 times a day. That can work. And then they can also use cold compress. They can just use a cold pack, apply it for 5 to 10 minutes, 2 to 3 times a day as well. So they can use both or they can use just one. So whatever provides relief to the patient, both of them can be safely advised to the patient. So very simple. No need. You don't need a physical therapist or even a rehab med specialist to do this. So it's a simple advice. And we also have another non-pharmacologic pain management. So we have your electrical therapy. So for electrical therapy, it provides analgesia through electrical nerve stimulation. So it works under the premise of the gate control theory. So some studies have shown conventional TENS actually resulted in a clinical benefit in patient assessment of change in the disease. So it actually works. So the one thing with your TENS devices, once you turn it off and once you remove it from the patient, the pain goes back already. So it's actually helpful if it's connected to the patient. So very short term ang pain relief. So my rehab hacks for electrical nerve stimulation. Well, they are readily available. No? You can purchase them online, you can purchase them in store, and they're relatively actually safe. And most of them are really made for home use. So just have to read the instructions. So, and most of the time they're very easy to operate unless the language settings are in Chinese. So you still have to translate them. Yeah? But they're pretty much very available. And it works, as I said. Huh? Now, the next rehab goal is the improvement of the range of motion. So we can actually also do some stretching. Yeah? So we just have to remember some principles. Like, for example, acutely inflamed joints, they should be rested to prevent exacerbation of symptoms. Now, for non-inflamed joints, active or active-assisted stretching of all major joints is essential to prevent contracture formation and maintain the current range of motion to perform most activities of daily living. Now, we can do it 1 to 3 repetitions of each exercise, of each stretching exercise, with 10-second holds performed once a day. So at least once a day, that can actually be beneficial already. And then for the week, stretching exercises can be done at least 4 to 5 days a week. Now, with each stretch being held for about 10 to 15 seconds also. So either you do it daily or you do it at least 4 to 5 days a week. So most days of the week, basically. So that will be beneficial also for the patient. Now, my rehab hacks for improving the range of motion. If the hands are involved, they can follow this simple guide. You can ask them to make a fist. They can do some thumb bending. They can do some finger bending. They can make their hands into an O. They can do table bends. They can do finger lifts. They can do fan and fist. They can do wrist stretch. So basically hand movements, no? Just have to stretch them out, hold it for a few seconds, and do it several times a day. That's already helpful for the patient. Okay, so it's already a stretching exercise. Now, if it's the feet are involved, they can do the following exercises. They can do a point and flex. They can do foot prayer positions, parang nagdadasal. They can do inner ankle stretches. They can do toe curls. They can do toe spreading. They can do standing toe curls. No? Very easy to do, very easy to teach. You don't really need a physical therapist. You just have to know what to do. No? Just show them a guide and patients can actually do them on their own. No? You just have to remember when they do stretching, they have to hold it for a few seconds. And they have to do it several times also for it to be effective. It's not just simply moving them. It's actually moving it and holding it in a certain position. Okay? Now, the next goal is the enhancement of strength and endurance. Okay? You can actually also do strengthening exercises. So, RA patients can actually do strengthening exercises. Okay, so studies have shown strengthening exercises could be utilized in non-inflamed joints. While isometric exercises, it's a type of contraction. It can help maintain strength to prevent injury or facilitate fatigue. Now, daily isometric contractions of about 10 to 20% of maximum tension held for 10 seconds can maintain isometric strength. And then in RA patients, studies also have shown that isometric exercises can lead to ADL performance with reduced effort and an increase in VO2 max. Actually makes them more efficient in doing some activities. No? If they were able to maintain their isometric exercises. You just have to remember then that these exercise programs, they should be progressed slowly while monitoring the patient for signs of inflammation. Okay, so my rehab hacks for strengthening, okay, so they can do the following. So they can do these finger movements, ask the patient to provide the resistance. So they can use their other hand to provide the resistance, do it on each finger, do it for several repetitions, and then they can also do it on the other side, on the other direction, so that both movements are actually strengthened. They can also do this movement wherein they can curl the fingers, grasp it over the other hand, and try to pull it away. So it's a simple isometric exercise for the hands that can be easily instructed to the patient. For the If the feet naman are involved, again, we can teach them the following. So if you remember the previous slide, the stretching of the feet, you can actually do them again. But this time, we add the resistance also, so they can do it, patients themselves. So just ask them to use their hands to resist it and do the exercises as specified in the other picture with some resistance. Okay, so that's my rehab hack for the feet strengthening. Now, my other rehab hacks for strengthening, if they can also do water-based exercises, they can use machines, they can even use their own body weights. They just have to remember the following principle. They can do these exercises 2 to 3 times a week with rest day in between, so to allow them to recover, no? And then to do light to moderate intensity exercises. They can do 1 to 3 sets of 10 to 15 repetitions of that particular exercise. And then they can focus also on muscles surrounding or those nearby affected joints. So for example, if the hands are affected, they can also strengthen the wrist and the elbow, and the shoulders. If it's the feet, they can also strengthen the ankles and the knees as well. So it can be done, and it can be easily advised again. Okay. What about aerobic exercises, the endurance part? Okay, so studies again have shown the benefits. So high intensity exercises are effective in improving functional ability, aerobic fitness, and muscle strength. And it does not appear to promote worsening of RA in terms of radiographic progression. So it can be done safely. Now, short-term intense exercise program consisting of dynamic and isometric strengthening and cycling could improve muscle strength without deleterious effect on disease activity. So again, another point in allowing aerobic exercise for RA patients. Then in another study, okay, in water exercises, it could decrease the force against the joints, and if it's a heated pool, it could help decrease joint pain and it can decrease muscle spasms. And there has been a note of an increase in the strength and endurance from water exercise programs. So it's actually beneficial also. So they can do their aerobic exercises while in the pool. So my rehab hack for this one, okay, they can actually engage in aerobic exercises. So it's okay, no? They just have to follow the basic principles. They can do aerobic exercises when the pain is lowest. Syempre dapat walang pain, no? Kasi definitely it will be difficult for them to move. Or at least when the pain meds are most effective. So they have a window time wherein they can actually exercise. But of course, they have to time it also well, no? Now, these patients, they can start at 10 to 15 minutes per session and gradually add about 5 minutes every 2 weeks until they reach about 30 minutes. And then, of course, the choice of activities are the low-impact exercises like walking, cycling, and swimming. Okay. Now, next goal is the prevention of correction of deformities, especially for long-standing or as the disease progresses. Maybe not for early cases, but eventually they might reach this point. So this slide shows the typical deformity of a hand with rheumatoid arthritis. So they develop their bottom-ear deformities, they develop their ulnar drifts, they develop their swan-neck deformities. Can actually provide an orthosis, such as an ulnar drift splint and ring splints that can actually helpful for the patients to maintain their functionality and maintain the proper posture of their hands. Now, that's my rehab hack actually. So, although these orthoses, they're actually best if they are custom made. It's usually the occupational therapists who do these things. But online, I've been seeing already a lot of these orthoses available also. But of course, the best would still be a custom made. Now, if it's the feet, they will also develop these deformities. They have their bunions, their hallux valgus. You can actually get this orthosis or fabricate them custom made also, like your toe separators, your valgus splints, your bunion shields, your foot insoles, which are not really are not very cheap, unfortunately, but they can actually be helpful for the patient. And then even specialized shoes, no? So that the feet will be supported well, no? And that they will be able to walk comfortably. So that's my rehab also, hack also, no? So it can be a useful solution for patients with disease progression. Okay, and then next, the last rehab goal is patient education and counseling. So we advise them also on relative rest. So rest and energy conservation, it's very helpful, no, for locally inflamed joints. So energy conservation also, an interruption of daily activities lasting greater than 30 minutes appear to be beneficial for patients to manage pain and fatigue. So they just have to stop their activity if it's going to last more than 30 minutes to allow them to recover. And then once they've recovered, they can just simply continue with their activities. So it's simply conserving their energy, no? So that they can continue doing it at a later time, so that they can manage their pain and fatigue. However, this should be balanced also with the potential side effects of inactivity. If they do it naman for too long of a time in rest period, it will include a decrease in the range of motion, the loss of strength, altered joint loading response, and a decreased aerobic capacity if it's done naman extremely too much on the resting side. So it just has to be balanced out. Now, the best person also to consult on these are your occupational therapists, whom we work with closely. No? So we usually tell them the OTs, we can do an activity modification program for these RA patients, and they can actually identify these activities. Now, if we don't have an OT, we can just go back to our physiatric evaluation or a simple evaluation. Ask them about their functional capacity and their social history. What are the things that they usually do? What are the important events that they still want to continue doing? And at least it will help us identify what are the things that can be adjusted so that they can manage their pain and fatigue. It can be as simple as that. No? Now, another thing with the patient education counseling is about the adaptive equipment. No? So it can help address the independence of the patients in ADLs, such as self-care, feeding, hygiene, and grooming. And they can also be assisted by an occupational therapist for proper training as an adjunct to independent living. So there are actually tools that they can use, these adaptive equipment. So, for example, you have your built-up handles for your utensils so that they won't be grasping them fully, so that their joints of their hands can be preserved. No? They also have these universal cups, wherein you can actually just slide in your toothbrush or your brush without gripping it fully, and they can still perform brushing their teeth and brushing their hair. They can also make use of long-handled reachers so that they don't have to bend too much, and that their grip use can also be minimized. They can also make use of dressing up apparatus like sock reachers, for example, which can help them wear their socks. Even simple things like that are very beneficial for our patients. So it allows them to adapt. Okay. Now, most of these tools also, they're available online. So that's one thing nice about that's my rehab hack for it. So there are a lot of adaptive devices available. Okay. So my take-home message, that's my last slide. No? So take-home message, rehabilitation medicine can offer a wide range of non-pharmacologic management of RA and those suspected of RA. Okay? So you just have to remember my rehab hacks, and surely patients will be able to benefit in managing their rheumatoid arthritis. So thank you everyone for listening, and that's my last slide. Thank you and goodbye.
Okay, thank you to the Santiagos for your insightful talks. And we have many questions in the Q&A box, and I'll start off with these questions. There are about 4 questions here with similar themes. What is the difference between arthritis and rheumatic disease, leading to what's the difference between gout and RA? And somebody asked if there is psoriatic arthritis, can this also be RA? And maybe those three first. Dr. Santiago, who would like to answer first?
Hi, Dr. Zamora, and hello, everyone. So thank you. Very, very good question to begin this Q&A. So it is important to know na when you say rheumatic disease, that is the umbrella term for conditions affecting your joints and your bones and joints, no? And even the immune system. And when we say rheumatic disease, kasali dyan yung iba't ibang klase ng arthritis. Kasi when we say arthritis, that pertains to a disease of the joint itself. So meaning, ang pinaka-apektado dyan is yung joint mismo. But when we say rheumatic disease kasi, what is affected are the joints and also the structures surrounding the joints. So
The soft tissues.
Yes, the soft tissues like your tendons, your bursa, even your nerves and muscles. Tapos kasali rin sa rheumatic disease term ay yung mga diseases that affect our immune system. So really, it's the general or the umbrella term. And arthritis is just one of the types of rheumatic diseases. Thus, regarding the question on the difference between gout and rheumatoid arthritis, and also if a psoriasis patient develops arthritis. So, yun, very important to remember na there are many types of arthritis. There are more than 200 types of arthritis, and it really depends on the etiology. Pag sinabi natin gout, the main reason why you are experiencing arthritis, if you have gout, is because of high uric acid levels, which can lead to deposition of uric crystals in your joints. And this will be the one triggering inflammation. So iba naman yun sa rheumatoid arthritis as we discussed earlier kasi that one is autoimmune. You develop autoantibodies like your rheumatoid factor and your anti-CCP, and you have high levels of inflammation. So yun yung dahilan bakit ka nagkaka-rheumatoid arthritis. Now psoriasis, di ba, we know this to be a skin disease, but in 15% of patients, down the line, commonly, meron din nag-develop ng arthritis. And it's a special type of arthritis associated with psoriasis. So yun yung tinatawag na psoriatic arthritis. And sometimes, they can be mistaken for rheumatoid arthritis kasi some patients present with your usual symmetric polyarthritis. But it's a special type of arthritis associated with psoriasis or your psoriatic arthritis.
Ayun. And also at this point, maybe we can also add na it doesn't mean that if you have one arthritis, yun na yung arthritis mo, no? Because you can have several. Like a patient with psoriatic arthritis can have gouty arthritis, and eventually pwede siyang magka-osteoarthritis and etc. So it's really important to consult your doctors because magkakapareho minsan yung itsura ng mga sasakit na kasukasuan, pero iba-iba po yung gamutan. And baka lang po mas magandang ma-diagnose muna ng tama. Now we have two related questions for Dr. Don, no? Regarding hot and cold compresses. Is it alternating per day or meron daw bang days na for hot compresses only? And then also Don, regarding chiropractorship, chiro in general, is it helpful for pain relief?
All right, thank you for the questions. Now for the question about the modalities and when to use it, normally I would advise the patients that if for acute swelling or acute inflammation, usually we use cold compress first. Usually for the first 2 to 3 days, you may apply them for about 5 to 10 minutes every hour if it's acutely swollen, and then you may continue this for the next 2 to 3 days. Now, once the swelling subsides, you may start alternating it with some warm compress to continue resolving the swelling of the affected joint. But normally, at the onset, we give first cold compress, and then this can be followed eventually by a warm compress. And then that's the time that you may start alternating them. Okay, that's a general advice for most swollen joints. No? For some patients, they would prefer, well, whatever makes them feel better. No? So some patients, they would prefer a warm compress immediately. That would also work. And some would also prefer cold compress at the onset, and that would work also. Okay. Now the next question about chiropractor. Um, well, generally, it can help address some of the back pain. So, but for me, as a physiatrist, I would have to check first the status of the skeleton of the spine. No? Let's say we have an elderly patient. If there are signs of any osteoporosis on the back, then I would not recommend them to undergo any chiropractor sessions. No? I think that would be more harmful to the patient, as it can lead to some osteoporotic breaks in the back, especially if they will do their bone setting. So that's my take on it, no, about chiropractors. But generally, young individual, non-osteoporotic, that should be okay, I think.
And also, the chiropractor has to be a licensed chiropractor, di ba?
Oh, yes, of
Oh,
course.
yes, kasi marami din yung mga hindi natin
Pretend to
alam
be.
talaga. Oo. Okay, so nutrition. There are 2 questions about nutrition in people with RA. Any dietary recommendations? And then herbal supplementation. Meron bang mga katulong, or are these all, cure-alls? What can you say about these questions?
Ayan. Okay. So sa nutrition, di ba unlike gout, wherein there is a clear possible triggers na mga high purine diet. In rheumatoid arthritis, we don't really have strong recommendations yet for any dietary modification, but there are small studies. There are small studies that advocate and see benefit in anti-inflammatory types of food, or yung vegetable-based diets, and even Mediterranean diets. So in general, I try to advise patients to adopt a healthy diet. We also know that rheumatoid arthritis is strongly associated with cardiovascular disease. So it's very important for patients to have a good diet na high fiber, more on vegetables, and less on salt, less fatty food intake. Also to lessen the risk of developing cardiovascular disease. As to supplements, there are no approved supplements. There are no yung mga food supplements that can really prevent or help in managing patients with rheumatoid arthritis. However, we know that rheumatoid arthritis can also predispose a patient to develop osteoporosis. That's why we usually give calcium and vitamin D supplementation for patients with rheumatoid arthritis.
Okay, maybe last question. What happens if RA is left untreated, and lifetime na nga ba ang treatment for RA?
Yeah. So, yung rheumatoid arthritis, I think we discussed some of the complications, especially Dr. Don. He showed the deformities that can happen if it is left untreated. Of course, number one, your patient will be in chronic pain, which we do not want that to happen, di ba? So it can lead to a lot of complications like depression and functional limitations. Tapos, if left untreated, this chronic inflammation in your joints can really cause erosions, damage, and will lead to disability. So yun yung mga kailangan natin tandaan. That's why it's very important to get our disease-modifying anti-rheumatic drugs early in the management of our patients. Tapos, rheumatoid arthritis is a chronic disease. So you will need maintenance medications. It doesn't always mean that you will have medications at high doses. There is what we call tapering. So once you've achieved your disease targets, and once you are maintained on those targets, sometimes pwedeng clinical strategy or treatment strategy is to taper your medications to the lowest possible dose. But likely, you will be on maintenance disease-modifying anti-rheumatic drugs.
Okay. I believe we don't have much time, but maybe one more, no? Ito yung mga regarding stem cell therapy. And what is your thought regarding testimony of people who practice the carnivore diet? Marami talagang mga ganitong thoughts, not just in the Philippines, but mostly third world countries, because not everybody has access to directly contacting their physicians and asking all these questions. So maybe those two, and then we'll wrap up the session. Thank you, doctors.
Ano yung carnivorous diet?
Daw.
Meat yun, no? Red meat.
Ah.
Oo. Actually, may studies na linking high red meat intake to RA. So parang ako, I would still go for a balanced diet. I don't think mga extreme diets are beneficial, especially to our patients with inflammatory arthritis. Tapos, stem cell, sa ngayon wala pa talagang clear evidence. So, di ba yung testimonial evidence, that's the lowest form of evidence. Kasi we don't know if what is true for just one person will be true to majority of patients with rheumatoid arthritis. So, we need studies to establish the benefit of stem cell treatment in RA, whether it is beneficial and safe. So at this point, hindi ko pa siya talaga mare-recommend. Siguro ano na yan, parang pag talagang walang gumagana, di ba? Parang yun mga last line alternative treatments. But for now, it is not recommended.
Yes, for now, I believe it's just for systemic sclerosis that there are there is a data. Yes, but not really for other autoimmune rheumatologic conditions. So there you go. Thank you, Doctora and Dr. Santiago, the Santiagos, for answering those questions. Medyo marami pa, and most of them were answered directly. And thank you to the audience for your interesting questions. So this afternoon, we learned that it's important to diagnose rheumatoid arthritis early, ideally within the first 3 to 6 months of disease, and to treat early with DMARDs for better outcomes. And then there are known risk factors for disease, and numerous studies are underway on the preclinical phase of RA and the prevention of RA. And as doctors, it is important to recognize these risk factors in patients presenting with non-specific arthritis, so we can monitor closely and diagnose and treat early if needed. And Dr. Don Santiago also talked about rehab hacks. And our rehab doctors and physical therapists can also offer a wide range of non-pharmacologic management for rheumatoid arthritis and other kinds of arthritis. And these are through different modalities, improvement in range of motion, strength and endurance training, prevention and correction of deformities using orthosis, as well as, most importantly, of course, patient education and counseling. So there you go. Please be reminded of the link for the evaluation form, and this is seen in our chat box. And to avoid any inconvenience regarding the certificate of attendance, please type in your complete name and the correct email address where you want your certificate to be sent. And we'd like to thank the Information Management Service Network team of UP Manila and our sponsor, Pfizer. Thank you all for joining us as we end this webinar, and we hope to see you all on November 23 for the LMLR webinar on joint and back pains when you're 50. Have a great afternoon, everybody.